Good morning, everyone. Today we are going to see the diagnosis and management of thyroid nodules and thyroid cancer during pregnancy. Disclaimer: this video is intended for educational purpose only, not a substitute for professional medical advice, diagnosis, or treatment. The content is designed to enhance learning and should not be used to make clinical decisions without consulting a qualified healthcare professional. Prevalence. Before we are going to see the clinical history and examination of thyroid nodule, first we have to know the prevalence of thyroid nodules in pregnancy. Usually the thyroid nodules and thyroid cancer is more common during pregnancy compared to general population. The prevalence of thyroid nodules in pregnancy range from 3 to 21%, and the cancer rate of thyroid nodules diagnosed in pregnancy has been reported to be 12 to 43%. Why thyroid nodules and thyroid cancer is more common during pregnancy? Because during pregnancy, placenta secretes human choriogonadotropin, which is molecular structure wise similar to thyroid stimulating hormone. So it stimulates the thyroid gland to increase in size. The size increase was 10% in iodine sufficient areas and 40% in iodine deficient areas. So the pregnancy is associated with increase in size of pre-existing nodules as well as all new nodule formation. First, we have to ask the clinical history with the patient who are coming with thyroid swelling during pregnancy. First, when it was noticed, before pregnancy or during pregnancy, and then how frequently the size was increased. Any pain or tenderness is there. If pain or tenderness is there, it's most probably benign. If suddenly increase in size, it's associated with hemorrhage. And then we have to ask the patient about the symptoms of local compression like dysphagia, difficulty in speaking, and then any change in voice, like that we have to ask. And then systemic thyroid symptoms like palpitations, breathlessness, cold intolerance, heat intolerance. And then you have to ask about the any history of family history of thyroid cancer, and then we have to ask the any history of previous head and neck or cranial irradiation. Then we'll go to the examination. General examination, we have to see the any signs of tremor, symptoms of hyperthyroidism, or any coarse skin, symptoms of hypothyroidism. Neck inspection, you have to see any enlargement of the thyroid gland. Palpation, you have to see the size of the thyroid gland. If it's uniform in structure, it's most probably benign. If it's irregular in structure, it's most probably malignant. And then consistency, if cystic in consistency, it's mostly benign. If it's hard in consistency, it's malignant. Mobility also assessed. If it's fixed to the underlying structure, most probably it's malignant. If it's freely mobile, the possibility of benign will be high. Cervical lymph node examination is very important in thyroid examination. In cervical lymph node examination, we have to see any enlargement of the lymph nodes. If lymph node enlargement is there, then we have to see the consistency of the nodule. If consistency is odd in consistency, odd or form in consistency, the chance of malignancy will be high. The papillary carcinoma of thyroid is the cancer which commonly metastasis to the lymph nodes. And then facial signs like Pemberton sign, we have to ask the patient to lift the both upper limb, and then any vascular congestion is there, we have to see. If vascular congestion is there, then the retrosternal mass is there. Laryngoscopy is done to rule out the involvement of recurrent laryngeal nerve. Then investigation. First, any thyroid swelling, first we have to measure the TSH level because it's very important. We have to see the thyroid nodule is active or the patient is in euthyroid state. If the patient thyroid nodule is active, if TSH is suppressed, the management completely differs. But during pregnancy, the unique challenge is there. Already I explained in physiology, the HCG is similar to the TSH. So usually in first trimester, TSH level will be low. So it's very difficult for us to measure. The TSH level is due to the excess thyroid hormone secreted by thyroid gland or due to the SCG secreted during pregnancy. Radionuclide scans like are contraindicated during pregnancy due to fetal irradiation. Routine measurement of baseline serum thyroglobulin or calcitonin is not recommended. Neck ultrasound remains the most accurate and safe imaging method for detection of thyroid nodules, accessing their pattern and features, and surveying for cervical lymph nodes in pregnancy. So we have to follow the ACR thyroid system, American College of Radiology thyroid system, based on the echogenic composition, shape, margin, and echogenic foci. The scorings are obtained. Based on the scorings and size of the nodule, FNAC will be targeted. If the person's nodule is fit, criteria is fit for FNAC, then we have to go for FNAC. But FNAC, like general population, there is no difference between the general population and the pregnancy, as pregnancy does not seems to modify cellular response at the microscopic level. The same diagnostic criteria for cytological evaluation as in non-pregnancy can be applied. FNAC is not contraindicated during pregnancy. Molecular testing cannot be currently recommended for evaluation of indeterminate thyroid pathology during pregnancy. So, if the FNAC source is a differentiated thyroid cancer diagnosed during early pregnancy, we have to do serial monitoring with ultrasounds, because pregnancy does not worsen the prognosis. Timing of intervention for small low risk tumors, we have to monitor throughout the pregnancy. If the tumor is aggressive and large, then we can plan for surgery in the second trimester. So even for mapillary microcarcinoma less than 1 centimeter, based on the Japanese trial, only the active surveillance only enough with neck ultrasound every trimester. Surgical considerations only for tumors with metastasis. The surgery also most probably planned in the second trimester to avoid miscarriage and preterm labor. Radioactive iodine therapy is contraindicated during pregnancy because of fetal harm effects. So, in thyroid hormone management, how you manage the thyroid hormone? TSH suppression therapy maintain the preconception levels. Levothyroxine dose increases during 30% during pregnancy. Every 4 weeks you have to do TSH level until 20 weeks, because already I told in the first trimester the TSH is suppressed due to physiological effects. Postpartum and preconception considerations. Postpartum monitoring, adjust levothyroxine based on TSH levels and thyroglobulin levels. Repeat neck ultrasound postpartum. Preconception planning, if they are taking radioiodine therapy, you have to avoid pregnancy for 6 months in women and avoid 4 months for male. Ensure thyroid function stable before conception. Special consideration, medullary and anaplastic thyroid carcinoma, we have to undergo advised surgery in second trimester. Tyrosine kinase inhibitors are not recommended during pregnancy. These are my references. Thank you.